Oh, are we doing the case first or second?
Oh my gosh, you're right. I'm so sorry. Brianna,
No,
I can share your screen.
okay.
Sorry. It's really like a crazy day today.
No, it's all right. My Zoom decided that it was time to update today, hence to being 5 minutes late. So
Oh
yeah, the
no.
crazy day.
It
Um,
really has. Just give me 1 minute. Thank you. Sorry about that. All right, can everyone see that okay?
Okay, you guys ready?
Mm.
All right, this is a 49-year-old male with a 20-year plus history of drug abuse. Meth, fentanyl, heroin being his drugs of choice. He is currently in a sober living program, which he entered about 4 weeks ago. He reached out to them because he was wanting to get some help. He's been clean 30 days at this point, a little bit more than that since I filled this form out. He's been clean probably about 6 weeks as of now. He was homeless previously, but now he says he's got some support outside of the program once he gets out. He does have diagnosis of hypertension, GERD, hyperlipidemia, hypothyroidism, and some vitamin D deficiency. His meds are pretty simple, all the way down through that list. We are supplementing his low vitamin D. His prior treatment history. So he was approved for an 8-week course of Maverick back in November of 2023. He claims that he was unable to complete this because he was homeless and his medication was ruined in the rain. Uh, from what I've spoke to him, he says that he was able to complete about 3 weeks worth of the medicine before the rest was ruined. So he never did pick up his second or his refill. So we lost contact with him after multiple attempts to reach him. We were never able to get a hold of him until he came back around for the program. We now see him almost weekly, and we have for about 6 weeks now. He's been really compliant with us this time around. He has been vaccinated for Hep B. He was immune to Hep A. Going down through there, his labs were all fairly normal. His ALT and AST was slightly elevated. His APRI score is 0.733. Kyle Turco Q was a class A, and his MELD score was a 6. The rest of those, the iron, vitamin D, which is low, we're supplementing, like I said. His viral load was pretty high, 29 million. I've never seen one that high before, just me. And I guess we just wanted to know what you all feel like would be a good treatment for him moving forward since we tried to treat him so recently in November. We do have liver ultrasound ordered on him right now, but we don't have results at this time. And are there any medication interaction that we should be aware of?
Thank you so very much. All right, does anybody have any questions before we go into the recommendations?
Elizabeth, would you mind pulling the CBC back up? I couldn't, I missed it. My bad.
No, you're fine. You want to, is that good, John?
That's perfect. Thank you.
Of
Thank you.
course.
Now I'm done staring at it.
I can keep it up if you guys need me to. All right, the recommendations portion, Dr. Gilface.
Man, that's a bummer because I wanted Kaylee on here, but I think she's stuck with a patient. So what I would do, by the way, thanks for presenting, Brianna. That's a bummer of a case, actually, but really a good example of what we're seeing more and more of now. Actually, I do have a question. See, when you opened the floor for questions, I said there was no questions, and now I have one. Brianna, how did you guys treat this patient before? Was this through like the HAMP program, or was it just done on your own, or how did you get them treated before? Out of curiosity.
I think the guidelines were that we could just submit him to like his insurance for approval at that time because he had never been treated in the past. Robin can correct me if I'm wrong. I was coming in whenever we were getting his process going. So I don't know that we presented him, but I could be wrong about that.
Okay, yeah, I was just curious. Um, what I would do in this case is wait a little while. I would, you know, best intentions are what they are. But I would add sort of best intentions plus time in this scenario. Let him prove more than 6 weeks that he's in a good spot. This is not a medical concept. It's more a socioeconomic human concept. Let's just make sure we're not going to backslide because you got one more shot, literally one more shot. So the medical question you ask is a great one, and it's can you simply retreat him? The answer is no. This would qualify as treatment exposed, treatment experienced, and the next treatment would be Vosevi. So you'd have to go to one of those two, but I wouldn't go there. I would honestly wait a little while. So Kaylee and I were talking about this case earlier and trying to think if we even, maybe recommend NS5A testing on him. Probably not. Remember, that's that test if you're cirrhotic genotype 3, that you want to do some polymorphism testing before you give somebody Epclusa. But in this scenario, I think you just got to call him treatment exposed or treatment experienced. And the definition of that's a challenge because there's no great definition of it. But 3 weeks worth, I'd count him as a treatment failure, even though it's not necessarily from a resistance standpoint. And the issue is, you really, really want to not jump quickly into that one because I'm assuming his payer is probably the government. It's probably a Medicaid program. Yeah.
All right.
And, you're going to have some extraordinary measures of proof before they're going to really be excited about paying for a more expensive treatment. And more important, honestly, from a functional standpoint, you don't want to burn that bridge from too early. So that would be my thoughts on him. He's a genotype 3, which always makes people sweat. He is one of these people that is developing fibrosis. So he's got an APRI that's a little bit elevated. It's in the realm 0.7 or greater suggests yes, I have some scar tissue, but I'm not cirrhotic. And that's kind of what his FibroSure says too. It says I've got some scar tissue, but I'm not cirrhotic. And but those are the people that can progress, and certainly in the setting of other insult to the liver too. So I'd give them all the generic good living advice. Healthy weight, healthy diet, healthy avoidance of alcohol, and see how life goes. And really, I'd give them more time before I'd contemplate treatment. I don't have so I'd say he needs to be not homeless and out of sober living and in a stable environment, and then revisit it. And then the medical decision making, as I mentioned, Kaylee's on now, so she can probably she was for a second. She could give you more medical rationale than I. She's more up to date on the retreatment stuff, but
Oh, she is. I see her. Thank you so much, Dr. Gilfus. Go ahead, Dr. Rexer.
sure.
Well, I was just going to say, based on my recent experience trying to get someone treated who had taken 4 weeks of a treatment a couple of years ago, the only thing I could get Medicaid to approve was 16 weeks of, I think it was Mavorite. So that's what we're doing for the guy. So you may run into the Medicaid bureaucracy in trying to get this guy treated.
Yeah, I see that a lot. A whole lot.
Hey, Kaylee, I had talked a little bit about our discussion from earlier that you were teaching me about what counts as exposed and stuff like that. But feel free to fill in because my explanation was subpar, I'm sure.
It was subpar. I'm sorry, I was in with a patient and got out really late. But yeah, I would really, the guidance is kind of funky. Is Rachel on here? She might be able to attest to it too, but I wish that they gave a threshold of how long or how much exposure to the medicine before they would count you as a retreatment. Because if you've only had a few days of Mavorite or even a week or two before a period of a several month break, we wouldn't expect that resistance to develop. But that's not mentioned in the guidance. And so we don't really have a way to justify, just straightforward treating with a course of Epclusa or something like that instead of using the same agent. And then, as Dr. Rexford said, there is that Medicaid preferred of 16 weeks Mavorite. So unless you can, justify, since that's his prior exposure of Vosevi, I would probably do an S5A testing just to be most prudent. And then I would probably just be a little bit cautious in treating him or trying to treat him too quickly, since he's just had a pretty short term recovery or back in care period. I usually follow people for a while before I offer them a retreatment.
Okay. Thank you,
Thanks.
guys.
Yeah, thank you. Some really great feedback. Any other questions, Brianna or Robin?
Not from me, unless Robin has any questions.
The only other thing I was gonna say is keep an eye on is, if he goes a time period without being treated, you keep an eye on that fibrosis markers and, if they advance before he's in a stable situation where retreatment becomes an option, HCC screening could become indicated in him regardless, if he gets up to significant scar tissue F3, F4. So hopefully not. Hopefully get him retreated before that. Hopefully gets in a stable spot. So
Yes, hopefully.
Rachel, do you know with the Medicaid criteria, if it was a treatment failure with Mavorite, do they, in that case, do they prefer the Vosevi for 12, or do they want you to do like the whole Mavorite and Riba and plus the Fosbuvir stuff?
Yeah, for their anything with a protease inhibitor right now, the Medicaid guidelines, they do allow Vosevi.
Okay, good.
If it's a treatment through or genotype 3 and cirrhotic,
Okay.
then they add the weight-based ribavirin, but they'll allow the Vosevi if it's got a protease inhibitor like Zepatier or Mavorite.
Oh, good. Okay. Well, that's good at least. And then you don't have to worry about the Mavorite for 616. Yeah. Okay. Thank you.
Great. Thank you so much. As always, you guys are wonderful. And thank you so much for submitting the case, Brianna and Robin. All right, Dr. Gilfus, the floor is yours.
I don't know why I'm struggling with getting my I can't find
You're just still on mute, Dr. Gilfus.
yeah, no, actually there was no, I was having a brain issue. By the way, I love that you stopped the recording while I was fumbling. That's awesome. Thank
Yeah,
you.
it's great, right?
Good
I need to do
editing.
it more for myself.
You're ready for Nat Geo, man. That's jealous. There was jealousy in that jibe, by the way. I think it's awesome.
Thank
I'm a
you.
paid subscriber. I love it. So anyway, actually, guys, we're gonna hear Dr. Feinberg today, who's always more dynamic and entertaining than I am. And but I'm gonna drone on about Hep B. And as usual, I love questions because that's better. I don't know if I'll finish everything, but that's okay. I have a PowerPoint, but I'm not going to use it extensively, just kind of guide you to the most important words on the slide. It's a DNA virus. So that's different. It's one that your body doesn't cure itself from very often. This little virus forms, and is little, forms many chromosomes, and you have it, Think of it sort of like a herpes virus or something like that. It's not a herpes virus, but it's similar in it being a DNA virus. and you can't necessarily get rid of it. There's some important gene products, but I'm not going to bore you on the ones that don't matter. I just want to mention that the core, the core antigen is never excreted into the blood. So you can't do an assay for core antigen. It's not possible. So all you can do is an antibody toward the core. For the surface antigen, you can do obviously antigen and antibody. And I do need to mention this by name. So the E antigen is, renowned for being a marker of infectivity. It's a marker of active infection. And then the antibody is a good thing because that means you're sort of on your way towards getting better. But there are some mutants, there are some genotypes for hepatitis B that don't have the E antigen. Just to confuse you, the name for those is called the pre-core mutants. Now, I wish more than anything they were called like the pre-E absent or just the E absent mutants, but they're not. They're called pre-core. And the reason this is pertinent is if you do see a patient with hepatitis B and you order a genotype on those patients, which I'd advocate you do just at baseline, do a baseline genotype, you don't get a number like you do for Hep C that's like 1 through 6. You get some words. And one of the words you might see is pre-core mutant, yay or nay. And what that says is your E antigen going to be reliably produced or not? And if you have a pre-core antigen genotype, it means that you can't follow the E antigen and you can't use the E antibody to tell you anything about their disease control. So that's that stuff. Again, ask questions, please, if you have any. Couple other cool gene products that you need to know about is there's a DNA polymerase that goes through an RNA intermediate, which sounds complicated, and it is probably needlessly so. And whenever nature does something needlessly complicated, there's probably a purpose for it. And the purpose is to create a lot of variety in your progeny. If you produce a couple 100 million times a day, you don't really require high fidelity offspring. And if you're a virus, you don't care about such things. Yeah, you just want variety so that maybe you could beat immune systems and maybe advance evolutionarily, etc. So this has this weird DNA to RNA to DNA copying mechanism. And the only reason that matters to us clinically is we can use antiretrovirals to treat Hep B. And Hep B is not a retrovirus, but because this DNA polymerase goes through an RNA intermediate, you can use HIV medicines to treat it. And that's an awesome thing. Not all of them, but the ones that target sort of the RNA to DNA copy, which is pretty darn cool and darn lucky, by the way. The other thing you need to know is there's a protein in Hep B that is an oncogene, a genuine cancer promoter. And so remember, Hep C can cause hepatocellular cancer through the ongoing cycle of scar tissue formation and inflammation and healing and scar tissue formation and healing, etc. So it's that milieu that leads to oncogenesis. For Hep B, you can go straight to cancer without the scar tissue. And that's why it's scarier in my mind from a cancer standpoint, because you can have somebody with a low F score and a fairly normal looking liver who can get liver cancer. So that's bad, obviously. It's transmitted a little bit differently than hepatitis C insofar as it's in more body fluids at higher concentrations, and sex becomes a major mechanism of transmission. Remember, for Hep C, we only talk of sexual transmission as being really uncommon and inefficient. And often we talk about having to be immunocompromised and having to be more anal intercourse that leads to Hep C transmission via sex. Well, in this situation with Hep B, it becomes efficiently transmitted through all forms of sexual intercourse. I shouldn't say all forms. I'm not sure about oral. I've never read on that exactly, but at least vaginal and anal for sure. The other part that's different than a Hep C is it's incredibly good at perinatal transmission. Very, very good. Whereas a fairly low frequency of transmission for Hep C, we quote that 5 to 7% or higher if you're immunocompromised. You really see a lot of mother to child transmission with Hep B. And of course, you can get it the same way as Hep C through needles, tattoos, blood-rich environments, et cetera, et cetera. So, but it's a little different. Hep B globally is an even bigger problem than Hep C. That's what this slide says. And it just says that, man, it's a major leading cause of chronic liver disease, liver cancer, and death worldwide. It is wild, you know, how people catch hepatitis B. Sorry, I got my letters reversed. B. How you catch hepatitis B really varies depending upon the country you live in. And the prevalence in your population. So I would say that 9 out of 10 of patients I see in my clinic for hepatitis B are foreign born and come from countries of high endemicity, so highly endemic countries. And their risk factors are unidentified. They don't have any identified risk factors. They probably got this at birth. So the primary risk factor in these highly endemic countries is vertical mother-to-child transmission at time of childbirth, and that's a bummer because you know it's harder to break that cycle. Vaccination can help, but not if the transmission has already occurred. So and now we're like North America and a lot of Western Europe and other places that we consider more developed countries. It's primarily the mechanisms I talked about. It's sex and percutaneous. So interesting. I'm not sure how clinically useful, but other than if you do see a patient who is from Africa or Asia and they can't identify a risk factor, this is probably not recall bias. It's probably because they didn't remember being born. Hepatitis B can do this stuff. So chronic infection, cirrhosis, and cancer, and you can see the numbers here are pretty dismal. They're kind of similar to the continuum that you see for Hep C with regard to the percentage of patients who go on to develop cirrhosis. Again, a little bit higher percentage can go on to HCC due to that oncogene, and we have to be a little more concerned about screening even those without scar tissue, but just says it's bad. And here's a picture of where high and low endemic areas are. In the US, it's less common than Hep C. It's about like HIV. So the numbers sort of trace HIV, more like 1 million people or so infected. And I guess that one bit of good news is about the same number of new infections occur each year as we see for acute Hep C, but far fewer of these will go on to become chronic. And I'll talk about that in a second. And so that's one of the blessings of Hep B. Is that most exposures as adults don't turn chronic. And that's very, very different than Hep C. And I'm sure this is a slide surprises nobody. By the way, a lot of this slide set is from Dr. Feinberg. And, you know, she always is so good at telling the epidemiology locally and the story behind these scary looking graphs of poor West Virginia, especially the southern part. And just suffice it to say, it sort of follows where we have problems with Hep C as well. Now you can see there are interventions you can do, and that's like vaccinate. So you can target your vaccination campaigns and so on and so forth. So one of the big advantages of Hep B over Hep C from a prevention standpoint is we have a beautiful vaccine that we can use to prevent stuff. Now, this is that sort of bit of good news that I was mentioning, at least for if you live in the United States. So the age at which you're exposed tends to dictate how likely you are to develop chronic infection. So if you're exposed as a little one, mother-to-child transmission perinatally, you're very likely to go on to have chronic infection. So you can see that's like 90%. So that's why it's such a problem to break that cycle in a lot of the world is exposure happens at time of birth, high transmission rates and high rates of becoming chronically infected. Whereas if you're exposed as an adult, you have a 95% chance of getting rid of that on your own, which is rocket. That doesn't mean you're not going to have a crappy 6 months or 3 to 6 months while your acute hepatitis calms down, but you have a good chance of clearing it on your own. And that's wonderful. And that's very, very different than Hep C. Remember, we don't know the true rate of clearance of acute Hep C, but, you know, classically have been quoted at, 10 to 30%. Maybe it's even higher. We don't know. Now, the bit of bad news for an adult in Western society is since our exposures tend to be as adults, it's the adults that tend to be more symptomatic. And so the one nice thing, if you're a little kiddo born in a highly endemic area and you get exposed and you get chronic infection, you tend to not have symptoms up front. What you do is you pay for it down the road with your chronic infection causing cirrhosis and liver cancer in your 40s. But never having any symptoms of acute hepatitis. Whereas if you're exposed as an adult, you tend to have symptoms, but you tend not to have it chronically as often. And that's just very similar to Hep C here, in that it can cause chronic hepatitis, cirrhosis, cancer, blah, blah, blah. The only thing that's super different is this thing that says occult Hep B infection. And you can see arrows going both ways. And what this is really implying is that Hep B can do a relapsing phase. And so that's kind of different. So, you know, subclinical, yes. Acute hepatitis, yes. But then what we can get with Hep B is a flare or a relapse of what looks like an acute hepatitis. And it can be confusing clinically. And it really speaks to the fact this is a DNA virus that sort of can kind of come and go, almost herpetic-like, not as often as herpes or its family, but it can come and go in certain settings we'll talk about in a little bit. And as we mentioned, you know, high risk of cancer. The signs, if you do have an acute hepatitis, look like any other acute hepatitis. It looks like Hep A, it looks like acute Hep C, it looks like acute Hep E. You can't tell them apart. It all just seems like a stomach bug until you turn yellow and have dark urine. So now it does tend to be on the more severe end of the acute viral hepatitis. So I do see people get hospitalized with their acute Hep B with often quite a bit of GI intolerance and impressive liver enzymes into the thousands. So acute Hep B is scary. If you said, what's the scariest acute hepatitis on its own to me, probably it's acute Hep B. Actually, it would be Hep B plus Hep D, but without D, Hep B scares me more than Hep A or Hep C acutely, because it can go on to have a fulminant liver failure more commonly than the other ones on their own. Combo infections, that's a whole nother story. Now, I literally despise this part of every Hep B talk. So my Hep B serologies and antigens and antibody timeframes do not reward lectures, nor do they reward memory. So thankfully, they're super easy to find. And I look them up. You'd think after 20 years, I would have these like ingrained in my mind. I don't trust my mind. I go ahead and look them up a whole lot and make sure I can trace out patterns to get a good sense of where people are on the time scale of infection. I will say the most common reason I'm referred a patient for hepatitis B is because of an inadequate data set being collected. And it tends to lead to anxiety for the patient because they think they have acute Hep B or chronic Hep B. And the reality is they just didn't get enough data points collected that prove that you're on your way to getting better or you actually are already better. So I would advocate when hepatitis B enters the your possibility of a reality situation, you go ahead and collect all your data points and then graph it out so you can figure out where they are. So what can you check? You can check antigens, your S and your E. Remember, you can't check the C because it's not secreted in the blood. And you can check your antibodies against S, E, and C. And then you can check a DNA as well. So those are all your data points you can collect and really help you paint a picture of where you are. And yeah, I don't want to read all this stuff because all this is a verbal version of this slide. And it just says that different things come up at different times. And if you collect all your data points, you can plug them in and interpret where your patient is. You can get a sense if your patient is going to be an acute situation, has become chronic, or is on their way towards clearing, or so on and so forth. And this would be an example here of sort of what you'd expect during an acute phase. You'd see E antigen, DNA, and surface antigen high. And then as symptoms and everything get better over the next 6 months or so, those go away and you develop your antibodies to those. And then a chronic state would be those markers, those antigens of active process, the E antigen, the DNA, and the surface antigens stay persistent, and you never develop the antibodies to usually either of those, either the E or the S. Now, only caveat here, this is for more advanced, is if you have a pre-core mutant. Remember, pre-core mutants are not going to make the E antigen, so you don't expect an E antibody to ever be helpful. And then the nice thing is there's endless tables that you can Google that show you stuff like this of how to interpret all of the different combinations therein. So what should you check when you're just screening somebody? Really just a surface antigen, a surface antibody, and a total core. Don't check an IgM core unless you're asking the question, does this patient have an acute hepatitis? Because remember, the IgM core can persist and confuse people, even though it tends to decline in titer. We often don't get titers with that. So don't check the IgM unless the clinical question is this an acute hepatitis? How about that isolated core? I feel like this group knows this very well, but isolated core can mean false positive, although I'd rarely call it that. It could be being in this window period right here. So where you don't find the surface antigen, you don't find the surface antibody in this time period right here, you can find the core. That can be isolated core. Resolved Hep B infection with waning surface antigen titers, surface antibody titers, sorry. That's rare, but can certainly happen. And then the one that we are all finely in tune with is having concomitant Hep C co-infection that sort of suppresses everything except that core antibody. And those are those serologically silent or sort of occult Hep B, Hep C co-infection patients. So what do we do with those patients? If we do have isolated core, we want to look for our other markers that might not have been in our initial screening studies, our surface antigen, surface antibody, and total core. So we'd want to go ahead and collect our E, antigen and antibody, and Hep B PCR. And question always comes up, should you vaccinate those isolated core patients? The answer is really depends upon what your anti-E and anti-E antigen and DNA show. If they do confirm that your patient has in fact seen hepatitis B in the past, there's no reason to vaccinate them because it's not going to help, but it never will hurt. Never will hurt. Remember, when you're giving the vaccine, you're just giving itty bitty bits of the surface antigen, and that's not harmful. And it's the same thing that exists in massive quantities when your patient has active infection. So just giving them a little bit of surface antigen, not going to hurt them, but it's not going to help them either in those isolated core people. Now, hepatitis B is just like hepatitis C in that it is really an immune irritant. It makes the body PO'd. It has this chronic infection that it can't cure. And so it's very immunoactivating, I think even more so than Hep C. I think vasculitis and weird rashes and arthralgias are some of the most important things to keep in mind when you see a patient with Hep B. False positive serologies, really sort of an immunologic or rheumatologic milieu it can be there. And these can be bad. This vasculitis in particular can be impressive, much less so just a skin rash, but often solid organ vasculitis, such as affecting the heart and the GI tract and so on and so forth. So it's a bad actor when it does sort of go into that immune activation, extrahepatic manifestation concept. And just like Hep C can even flog the immune system long enough that it becomes a lymphoma. So bad stuff. But Hep B treatment, so I just want to juxtapose this to Hep C. Remember, when we say Hep C, our next statement is treat. We want to treat all patients with hepatitis C. With hepatitis B, due to that natural history of clearance of a large majority of adults, you want to drag your feet. So you just want to hold back and just see what's going to happen. You really don't want to rush into it. And furthermore, the treatment algorithms are complicated. The treatments are often not curative; they just control. And this is a huge one. If you have a patient who's not adherent with their medicines, it can jeopardize their own health. And so there's a million reasons to not rush into treatment for Hep B. In fact, I generally see patients for 2 or 3 visits over maybe even a year time period to get to know them before I offer them treatment for Hep B. I got to get to know them and trust them and make sure they really need it before we venture into it. The decision points, as opposed to Hep C, where we just want to treat everybody, thankfully, for Hep B, you want to treat people that you can benefit. And what I mean by that is, since we can't cure this and make it go away for sure, we want to use antivirals with a particular goal. And the particular goal are to improve any of these parameters. And so we really want to see what their E antigen status is. And again, this is complicated. You don't need to. Sometimes we do treat people even when their E antigen is negative. In fact, if they're a pre-core mutant, we're often more aggressive in our treatment approach. But we look at the E antigen, we look at their viral load. It's really important that we only treat people with elevated transaminases unless they're cirrhotic or a lot of fibrosis. And then again, we use F2 or higher as a sort of a warning sign for these patients. Do not need to know any of that stuff other than what data points we look at. And there are very complicated tables that sort of break this down into particular breakpoints of what viral loads in the setting of what F score, in the setting of what ALT and ST, and then setting of what genotype. So it's much more complicated. And I promise you, I look this up every time to make sure I'm calculating these variables correctly. So it's complicated. And we go into this concept of, who do we treat, who do not treat. I will tell you, there's this is per Dr. Feinberg's knowledge. I never have any secret backroom knowledge. I hope that comes with age, but Dr. Feinberg's always got all these cool data. Dr. Kaku also told me this too. The powers that be at the AASLD and IDSA are sort of pushing to eliminate this whole slide and sort of move Hep B more to like Hep C, where if you diagnose it, you treat it. That sounds good because it simplifies life, but it will probably lead to overtreatment. And again, treatment is complicated for Hep B because it's not curative and poor adherence can harm the patient. Our treatments are really HIV medicines, which is fascinating. They are the false substrates, so they're reverse transcriptase. They're nucleosides that get incorporated into an expanding DNA chain and cause chain termination. And so what we have here is tenofovir derivatives, the old one and the new one. They both work well, and a drug called entecavir, and they are well tolerated, very, very well tolerated. We know them. This is drugs we use for PrEP. These are drugs we use for HIV therapy. By the way, I don't think I have this in the slide, but PrEP works for obviously HIV. PrEP works for Hep B. Interestingly enough, that's not why we use it. The best prevention strategy for Hep B is vaccination. But if you had a person who was unvaccinated or under-vaccinated and they were on PrEP for HIV, you are unintentionally prepping them against acquisition of Hep B as well. So what I would urge you to do if you do diagnose someone with chronic Hep B is don't rush, get to know them, make sure this isn't going to clear on their own, make sure they don't have Hep C, make sure they don't have HIV. The real reason for HIV is you'd never want to treat a patient with HIV with a single drug. And sometimes if you didn't know their HIV status and you decided just to treat their Hep B with, say, tenofovir alone, you could really jeopardize their future HIV therapy. So you want to make sure you look for these co-infections. If you do decide to treat people, you sort of use all those variables that we looked at before, and you try to improve them. So you try to get their AST and ALT to improve. So really, if they're not elevated at start, you're not going to improve on that. And so you really only want to treat people with elevated liver enzymes, those with elevated viral loads, and elevated F scores, and some combination therein. And you look for improvement on those. And then the real bummer is we don't know how long to treat people. So in general, what we do is we try to get everything to get better. So you get their liver enzymes better, you get the viral load undetectable, you get their fibrosis score hopefully improving, and then you try to get the E antigen to disappear and turn into anti-E. So turn into the E antibody. And then after that happens, you treat for a little longer, and then you can contemplate stopping. So, and any of you on here that are true sleuths, obviously that wouldn't work for a pre-core. So in those patients, we never stop treatment. But the punchline is we often don't know how to tell people how long they'll be on treatment. Before I launch into treatment, tell people they'll probably be on it forever, because I don't know. And I'd rather err on the side of being pessimistic than lying to patients and say it's going to be 3 or 4 years. So the resistance is a problem with these antiretrovirals these antivirals that we use for Hep B. And it is something that can happen even with good adherence, which is a bummer. But so you really kind of want to use good antivirals. But the ones I mentioned, entecavir and tenofovir, are good. We do have to be aware of this concept of this hepatitis B flares. So what is a Hep B flare? That's not something we talk about with Hep C. A Hep B flare is someone who's got quiet background Hep B that suddenly presents like an acute viral hepatitis. That can be that their liver enzymes go back up to a few thousand, or they turn yellow, or they have symptoms, or so on and so forth. So it just looks like an acute viral hepatitis, and it can happen in certain settings. The setting we talk about most of the time in this echo is when we treat Hep C and inadvertently unmask Hep B. And so remember that Hep C, Hep B competition in a hepatocyte, Hep C usually wins and sort of suppressing Hep B. And when we use our Harvoni or Epclusa or Mavorite for our Hep C, and Hep C is cured, and then suddenly Hep B is like, wait a second, I'm free to be the dominant virus now, and it can flare up. So that led to that black box warning that we all talk about for our Hep C patients that are Hep B co-infected. So that's one setting a flare can happen. This is the one that scares me like crazy, because patients can, on their own, be poorly adherent or stop taking or decide not to fill their tenofovir and entecavir and induce a flare. And so in general, if you have somebody taking antihypertensives and they stop taking their antihypertensives, it doesn't kill them right away, or if they stop taking their statin, it doesn't kill them. Whereas if they're taking Hep B drugs and they stop taking it for some reason or another, they move, they become homeless, they go to jail, blah, blah, blah. A flare, if you're a cirrhotic patient or a person with a lot of scar tissue, a flare can occur, and that can be very dangerous and bad. And so I'm really, really cautious about who I treat because of the concept of cessation of treatment flares. So other times you can see flares. Flares are sometimes good. Flares can happen when your body decides to beat hepatitis, which is cool. And then flares can happen whenever we sort of suppress the immune system and then let it wake back up. That happens after we give somebody cancer chemotherapy. It often is actually upon like sort of white blood cell count recovery. It also can be after you give somebody steroids. I've seen it for both steroids for poison ivy or COPD. So they do fine while they're taking the steroid taper. And then when that 6 to 12 days is over or whatever, you can see their hepatitis B suddenly wake up and flare, and that can be dangerous. Now, it interestingly can also be good. If it doesn't kill you, you might seroconvert. And so a Hep B flare is almost like a new acute viral hepatitis. And so remember, every time you have an acute Hep B viral hepatitis, you've got a 95% chance of beating it on your own. So a flare, you have another chance to beat it. But I don't think that's a good way to approach Hep B treatment, is inducing a flare and hoping your body beats it the second time. And so a couple things, I'm going to talk about two more topics and I'll let you go. Vaccination. We need to do a better job. There are new recommendations since 2023 that says we should screen more people and vaccinate more people. So basically, we should now screen just like we do for Hep A. I'm sorry, wrong word, for Hep C and HIV. So we should screen more people, even without risk factors. So risk factor pre-screening, we should screen during pregnancy, and of course, do risk factor-based screening. And the risk factor-based screening is kind of logical, what you'd think of for anything that's bloodborne or high risk sexual activity born. So you can see all the words on here, go to jail, go to STI clinic, have any other diseases associated with high risk behavioral or sexual activity, and so on and so forth, or come from endemic areas or blood rich environments. You should test people based on risk factors, and of course, screen risk factor free, and then link to vaccination, hopefully, if they're Hep B negative. And so really, this is a terrible slide and is emblematic of sort of vaccine uptake in general in adults. And, we don't like vaccines. I don't know why, but a lot of adults don't get their Hep B vaccine. I think I'm bad at remembering to offer Hep B vaccines to anyone except for people in my Hep C clinic. So, but we just need to do a better job. That's what that says. We have regular vaccines. These are the traditional 0, 1, and 6 month vaccines that contain surface antigen. And remember, there's an adjuvanted vaccine, the Heplisav, that is just at 0 and 1 month. That's a little more immunogenic, and so on and so forth. Who should be vaccinated? We really, the current verbiage is we should vaccinate those between 20 and 60 or 18 to 59. And then we can offer it even to those who are older. And in fact, we definitely should offer it to those who are older with risk factors of either having increased risk of acquiring Hep B or having inadvertently bad outcomes if they did ever get Hep B. So anybody with chronic liver disease or risk factors for exposure, even if they're older, should get Hep B vaccination. What do we do for those who are non-responders? Well, let me even step back. Certain people don't respond. This is one of the vaccines where there's a significant rate of non-response. This slide says 5 to 15%. So what we should do is contemplate actually checking for development of surface antibodies to make sure that your patient is not a non-responder. And in those situations, make sure, number one, that they don't actually have chronic Hep B. And so one of the algorithms is make sure that you check for that surface antigen again. Remember, don't do that right after you vaccinate them, or you're going to confuse the heck out of yourself. Remember, the surface antigen is what you actually give in the vaccine. And so you can confuse yourself by checking a surface antigen too soon after vaccinating somebody. But if you did have somebody who, say, underwent their 0, 1, and 6 month vaccination and didn't respond when assayed maybe 3 months down the road, first thing you'd want to do is recheck a surface antigen, make sure they don't actually have chronic Hep B. And if they don't, go ahead and restart a vaccine series of a different vaccine company. That was bad wording. I think you know what I mean. Choose a different one of those. And I think a lot of us these days would go to the adjuvanted vaccine that just requires the 2 shots because it is more immunogenic. And the last slide I'll leave you on is a bit of good news. Unlike Hep C, where we just sort of tell pregnant moms, good luck to you. I hope your baby doesn't catch Hep C. If you have Hep B and you're pregnant, there's something we can do. There's actually really, really good stuff we can do. We can put mom on antivirals 3rd trimester and get her viral load down really low. Furthermore, when the baby's born, we can give immunoglobulin and vaccination right away. And basically, this approach of antivirals to mom and some passive and active immunization of baby basically prevents transmission. It's like 99 point whatever. So it's really, really, really good. So this is a great thing. Much like HIV, mother-to-child transmission has been eliminated for the most part. Hep B can be as well. And yeah, that's the good news of mother-child. Even better though would be to not ever have mom have Hep B. So we can vaccinate everybody and have Hep B become a thing of the past. So with that, I'll stop. And thank you. Thank you. Any questions anybody's got?
Well, I first want to just say thank you so very much. Oh, Robin's waving her hand. Oh, go ahead. You're on mute still, Robin. We still can't hear. Robin, can you hear me?
Hey, sorry.
Oh, no.
So, the Hep B is probably one of the most confusing parts of this, but just to be clear, I have someone coming in actually right now for my Hep C clinic, and his core is positive. I'm making sure I understood everything correctly. So his core is positive. His IgM, Hep B core antibody IgM is negative. So would it be adequate if I just check, and he's, he doesn't have the surface antibodies, so he's not immune. So is it appropriate if I just check the PCR, the viral load, or do I need to check the HBsAg as well? Did I understand that correctly?
Yeah. I mean, so I love more data. So yes, you're perfect. You're perfect, Robin. Yeah. One of the things that e-antigen and e-antibody could help you with in this situation would be more confidence if this was actually a genuine exposure or not in the past. And it probably was. It probably sounds like if he has Hep C, this is probably one of those serologically, silent, isolated core positive patients. Right. And but yeah, so the power of checking the e-antibody is that if it's positive, it really gives you comfort that this guy saw this virus, genuinely has it. This is sitting in his body, and you somebody that I'm more cautious monitoring, even though it's incredibly unlikely to reactivate when you get a negative surface antigen. But it's somebody that would really give you more confidence that this was in his body and was real. Probably is, core antibody positive, so on and so forth. But yeah,
the E antibody and the PCR. I need to check today.
Yep. Okay. I would
check
E antigen, E antibody, and PCR, and then and they'll probably all be negative, okay. And we'll see how you go from there. But yes, thank you, Rob. Whenever you err on the side of what to collect more, and then you can get a really reliable picture of where you are on the natural history of Hep B. Okay. Thank you for clarifying, Robin. Great. See, you knew exactly. And by the way, I concur with you. It is the most confusing part of viral hepatology. And it's a bummer that it was discovered in 1960s because all we could do is describe it serologically. And I think we've made it needlessly complicated. Had it been discovered in the 2000s, we'd probably have a screening antibody test and a PCR, and life would be simpler. But that's not how it is. But yeah.
Okay, thanks a lot. Appreciate it.
Thank you so much. Excellent question. Anybody else have any questions? All right. Well, the only announcement I have, besides if you do have time to stick around, if you have any questions about the new IECO, I will remain here. But if not, you can schedule a time with Kelly or Jay to go over that. But the final announcement I have is the next time you'll be meeting is going to be May 23rd with Dr. Gilfus discussing Lyme disease prevention and treatments. So be sure to check into that because that's always on the rise, it feels like every year. But besides that, thank you everyone, and I hope you have a great rest of your week.